Hello everyone and welcome to MedFM. Now this video is going to be very important in our ECG series, and because in this video we will be talking about the abnormalities that can be seen in P wave, QRS complex and ST segment, and also in T wave. Okay, so please watch this video till the end, and I will try to make all these things easy, and we will be learning these things via the basic concepts behind them, okay, and why they are happening. So we will be starting with the abnormalities associated with the P wave. Okay, so P wave is the resultant vector of the depolarization vector from right and left atrium. Now right atrium and left atrium will influence the P wave. Okay, any changes in the right atrium and left atrium will influence the P wave. Now there are two parts of the P wave. We can divide this in two parts, this and this. Okay, the first part is because of the right atrium, the second part is because of the left atrium. Now suppose there is any change, any hypertrophy of the right atrium, that will increase the height of the first part of the P wave. Okay, so it will look like this, but as there is no hypertrophy of the left atrium, so it will look like this. Now if we connect this, so this will be the ECG if there is right atrial hypertrophy. Okay, if I again talk about the basics, why there is a positive P wave, because of the depolarization vector. Okay, any depolarization vector which is going towards the lead will give us a positive deflection. Here the right atrium and left atrium, as they get depolarized, the resultant vector goes toward the lead, and because of that there is a positive deflection. Any change in the muscle mass of the atrium or ventricle will increase the depolarization wave or decrease the depolarization wave if there is increase in muscle mass and decrease in muscle mass respectively. Okay, so this was the if there is right atrial hypertrophy, this is how the P wave will show us. Okay, now talking about the left atrial hypertrophy. So left atrial hypertrophy will give a peak to the later part of the P wave. Okay, so this will be the first part will be normal and the second part will have a peak. Now if I connect this both, so this will be a representation of the person who is having left atrial hypertrophy. Okay, so this will be the representation. Now if we look at this ECGs, so actually there is one catch here. When there is hypertrophy of the right atrium, okay, so there is peak wave in the first part of the P wave. Okay, so the first part of the P wave is more in height than the later part, so this gives us the effect of increased height. Okay, so you can say that the right atrial hypertrophy causes a increase in the height of the P wave. Okay, now when talking about the left atrial hypertrophy, as it gives a peak in the later part of the P wave. Okay, and because of this, the more effect is on the width of the P wave. Okay, so you can say that the left atrial hypertrophy influence more of width of the P wave, and the right atrial causes more height of the P wave. Now what are the reasons behind the right atrial hypertrophy? So they can be tricuspid valve stenosis or pulmonary hypertension. These are the most common causes of this right atrial hypertrophy. And the left atrial hypertrophy can be because of mitral stenosis. Okay, usually it is because of mitral stenosis. Now let's see ECGs of these two. So yeah, here see this. Okay, so the P wave changes with the right atrial enlargement. Now we are having here two leads here, which is the suppose here this is the normal ECG, and the lead to have a normal P wave, but the V1 shows this S pattern of the P wave normally. Why it is so? Because the V1 is V1, if I talk about the location of the V1, if this is our heart, V1 is looking the heart from this side, okay, from this side, the right, from the right above side, okay. So now when there is a depolarization of this wave, depolarization of the atrium, so the right atrial depolarization causes the positive deflection, and the left atrial depolarization causes the negative deflection, okay. The resultant vector, you can say why this resultant vector is here, because if I actually the location of the V1 should be here, okay. Now this right atrial depolarization vector is like this. The left atrial depolarization vector is like in this direction, okay, for the V1. Now the resultant vector will be in this direction, okay. So first the wave will go towards the V1, then go away from the V1, okay. So this was a basic idea behind why V1 is showing a curved or S type of wave, okay. So coming back to this photograph, so the P wave changes with the right atrial enlargement, so this was the normal. Now if there is right atrial enlargement in the second lead, we will be seeing the peaked part of the P wave. The earlier part will be showing the peak, and it is simple now as because the first part shows the right atrial in because of the first part is influenced by the right atrium, so there will be a peak in the right atrium, peak in the first part of the P wave, and there will be no change in the later part of the P wave in V1 lead, okay. Now if I talk about the left atrial enlargement and the second lead, so as you can see, this first part is normal, but the second part of this P wave is showing a enlarged left atrium, because of which there is more depolarization vector of the left atrium and more is the influence. Now what will happen to the V1 lead? Okay, see, normal first part of the P wave, earlier part is normal, and the later part is showing a more curved P wave. Why it is more curvy? Because of the left atrial enlargement. Now if there is enlargement of both right atrium and left atrium, it will show a peaked earlier part of the P wave and also the peaked later part of the P wave, okay. So and this will increase both height and width of the P wave. So and see here, because of the enlargement of both right atrium and left atrium, there will be more peak in the first part and more curvy and peak in the later part of the P wave, okay. So this was the basic about the enlargement of the atrium and influence of this enlargement on the P wave of the ECG. So now see this, as you can see, the P wave is more peaked here, okay. P wave, okay, more peaked here, and because of this more peak of the P wave, there is the left atrial wave, which is normal, is hidden inside it, okay. So there is a very minor change in this curvature, and that is where the left atrial wave is hidden, okay. So main change that you will see in the right atrial enlargement is because of the P wave, peak of the P wave, okay. Now see this ECG, okay. Now earlier part of this P wave is normal because there is normal right atrium, but the later part is curved, okay. So see, this is making a M pattern. Why M pattern? Because now the left atrium is also influencing the ECG in by its own more depolarization vector, okay, because of the enlargement. So this M pattern will be seen when there will be left atrial enlargement. I hope the concept is clear, that if there is left atrial enlargement, there will be more depolarization vector because of the left atrium, okay, and that will cause the more peak in the later part of the P wave, okay, and the right atrial enlargement will cause more peak in the earlier part of the P wave, that will hide the later part, which is because of the left atrium, and that will cause a peak that will increase the height of the P wave, okay. So this was all about the P wave. Now we will be talking about the abnormalities that are associated with QRS complex, okay. Abnormality that are associated with QRS complex, okay. So there are some points that you need to remember about the normal QRS complex. So it should be the not greater than 120 milliseconds, or you can say three small squares, okay. And in a right ventricular lead like V1, the S wave is greater than R wave. S wave is greater than R wave. We have talked about this in the basics of the ECG. So this is our heart, this is V1, okay. Now why there is S wave greater than R wave is simple, because left ventricle has more muscle mass, okay, and it is influencing more the vector, and because it is influencing more the vector, there will be more decreased in more negative depolarization vector, okay. So the vector which is because of the ventricular depolarization is going away from the lead V1, okay. And why there is positive R wave then? Why there is a positive R wave and negative S wave? So because R wave is because of the depolarization of the septum, which is having a vector towards V1, okay. So vector towards V1 because of the septal depolarization is causing the positive R wave, and because of the negative deflection is coming because there is a depolarization of the ventricle, and the depolarization vector is going away from the lead V1, okay. So this was the basic why the S wave is greater than R wave in this lead V1, okay. We are talking about the normal, okay. So in the left ventricular lead, now talking about the left ventricular lead, like V5 and V6, so V5 and V6, the height of the R wave should be less than 25 millimeter, okay. So this was the about the V5 and V6, okay. Okay, now let's talk about the abnormalities associated with the QRS complex, and okay. So now we will be talking about the why the QRS width of the QRS complex is increased. So we have talked about this in our basics videos of the ECG, that whenever there is increased width, that means there is something wrong with the conduction pathway, okay. So the conduction is the reason why the width of the any segment of or interval is increased. Now QRS complex width is increased, that means there is something abnormal with the conduction part. So this can be because of the conduction block, okay. And conduction block we have already discussed about the about this in our previous videos, so you can check it there. And other things that can be associated with the QRS complex width is the Wolff-Parkinson-White syndrome, W syndrome, that also increases the width of the QRS complex, okay. Now talking about the height of the QRS complex, it is very important part, okay. So why the height of the QRS complex will be increased? So we talked about that the QRS complex is because of the ventricular depolarization, okay, and it is predominant towards the left side and can be seen easily in the V6. QRS complex can be easily seen in the V6 because of the vector of the depolarization is going towards the lead V6. Why it is going towards the lead V6? Because left ventricle is having more muscle mass, and it will have more influence on the ECG, because the depolarization vector is more stronger and having more stronger for the V6. Okay, so now our main focus is on the height of the QRS complex. Okay, so QRS complex is because of the ventricular depolarization. Now more is the muscle mass, more is the depolarization vector, more influence on the QRS complex. And now suppose this is our heart. Okay, I am making only the ventricular part. Now normally what happens is, because there is more muscle mass in the left ventricle, the depolarization vector goes towards the left ventricle. Okay, so this is the normal depolarization vector that can be seen. Okay, this vector is the resultant of two vectors. The first one is because of the right ventricle, and the second one which is because of the left ventricle. But the magnitude of this left ventricular depolarization vector is more than the right ventricular depolarization vector. So the resultant vector is this, and the lead which is looking towards this is the V6. Okay, so the V6 lead will show more of the QRS complex can be easily seen in the lead V6. Now suppose there is increased muscle mass in the right ventricle. Okay, so suppose now if I draw it again, and okay, let me draw it again. So normally what happens, that this is left ventricular depolarization vector. Okay, and this is right ventricular depolarization vector. Okay, and hypothetically if I denote some values to them, suppose it is having a value of 100. Okay, it is having a value of 30. Okay, so the resultant vector is it is positive, it is negative. Okay, so the resultant vector is the positive 70 normally. Okay, now if I increase the muscle mass inside in the right ventricle, increasing the muscle mass will increase the value of the depolarization vector. Okay, magnitude of the depolarization vector. So now this depolarization vector is having a value of -70. Suppose it is having a value of -70. Okay, so now the resultant vector will go more towards the, this will be the resultant vector more towards the right ventricle. Okay, so and the value will be +30. Okay, so the value will change, and that will be less positive, and here by saying the less positive means it will be more towards the right side. Okay, so now the lead which was looking towards this ECG, the V6 lead. Okay, so first it was taking the vector was directly going towards the V6 lead. Okay, so we were getting, if I draw the ECG which is obtained from the V6 in a normal ECG, so this is Q wave. Okay, Q wave is because of the septal depolarization. Okay, and that occurs from left to right. Okay, so the vector goes away from the lead V6. Now this is the R wave, and R wave is because of the ventricular depolarization. Previously this ventricular depolarization was more, because the depolarization vector was going directly towards the V6 wave. Okay, and then the baseline was achieved. Okay, baseline was achieved. Now what will happen, because of the right ventricular depolarization, there will be Q wave. Okay, there is no effect on the septum, but there the height of the R wave will not be the same, and there will be a negative deflection, and the S wave can be seen here in the V6 lead. Okay, so it is the right ventricular hypertrophy that is causing this thing. What will happen to the V1 lead? Talking about the V1 lead, okay, so normally what happens in the lead V1, there is R wave. R wave is because of the, why R wave can be seen? R wave is because of the septal depolarization, and we have talked about the vector that is going towards the V1 lead. Now the second part is the S wave, and S wave was more negative as the vector was going away from the lead. So now what will happen? Think guys, what will happen? Now the vector is going more towards the right side. That does mean this part of the R wave was because of the septal depolarization, but now there will be more part of the R wave because of the ventricular depolarization, as the vector is going towards the right side, more towards the right side. And then the S wave, okay, S wave will be there, and then the baseline will be achieved. Okay, so in right ventricular hypertrophy, what can you see is the more R wave in the V1 lead and less S wave in V1 lead. Okay, also this pattern in the V6 lead, QRS complex in the V1 lead, and the R and the magnitude of the R wave will be delayed here. Okay, will be less here. So this was the basic concept behind right ventricular hypertrophy and left ventricular hypertrophy. I hope you now understand the concept behind this. Okay, now we will be seeing one ECG which is showing us the severe right ventricular hypertrophy. Okay, so let's see the lead V1. As you can see here, this there is the this R wave is increased in the height of, okay, and there is S wave. No Q wave can be seen in the V1. Okay, normally we cannot see Q wave in the V1, so increase in the height of the V1. Now let's see the V6. See this, the R wave is now having a less height, and there is one S wave which is having more height. Okay, which is having some significance here. Okay, so this is QRS complex and V6. So right ventricular hypertrophy, I hope you got my point. What is right ventricular hypertrophy and how we will be seeing the ECG in this. Okay, and let's talk about the next ECG, and this ECG is because of the pulmonary embolism. Now pulmonary embolism is a cause of right ventricular hypertrophy, and this shows right ventricular hypertrophy. Why this is happening? You can see guys, the right ventricle pumps the blood in the pulmonary artery. Okay, now pulmonary artery, if there is a blockage or embolism in the pulmonary artery, okay, semi blockage is there, so there will be that will require more contraction of the ventricle. Okay, more contraction of the ventricle. Now more resistant will cause more hypertrophy. Okay, that's the science behind the bodybuilding. More of the resistant, more of the breaking of the muscle and the regeneration of the muscle, and that will cause us that creates the hypertrophy of the body. So same mechanism works here. So more the force required to pump the blood, more will be the hypertrophy of the ventricular muscles. So the pulmonary embolism is will also show the features of the right ventricular hypertrophy. Okay, so and as what can we see here is the sinus tachycardia. Okay, sinus tachycardia can be seen here. So let's see. Now one more thing, if there is more force required for the right ventricle to pump, there will be more force required for the right atrium to pump the blood into right ventricle. Okay, so there will be a small amount of hypertrophy in right atrium also, that will give us the positive P wave. Okay, peaked P wave. Okay, we talked about the peaked P wave in the P wave section. Okay, so there will be more p waves. Okay, now one more thing that I would like to discuss here is that the change in this vector. Okay, see, this was the resultant vector because of the right ventricular hypertrophy. Okay, so you can see there is a right axis deviation. Okay, this was the normal, this was the pathologic. So there is a right axis deviation that can be seen in ECG because of the right ventricular hypertrophy. This right axis deviation can also be seen in an ECG which is obtained from a person who is having pulmonary embolism, because the pulmonary embolism is also eliciting the right ventricular hypertrophy. Okay, now here is an ECG which was obtained from a person who was having pulmonary embolism, and in this ECG you cannot appreciate the tall R wave here. Okay, the R wave is although small, but if I look towards the V6, here is the S wave. Okay, a negative S wave, and negative S wave denotes that there is a mass, there is ventricular depolarization, ventricular hypertrophy that is causing the vector more towards the to slide more towards the right side, and because of that there is a negative S wave in the V6 lead. Okay, and also we can see there is a peaked P wave in lead 2 that is denoting the right atrial hypertrophy. So that was two main points that we can see in this ECG because of a patient who is having pulmonary embolism. Other than this, we can see there is also the right ventricular hypertrophy also causes the T wave inversion. So you can see T wave inversion in lead V1, V2, V3 and also in V6. Okay, also in V4. So there is T wave inversion also can be seen in the right ventricular hypertrophy. One important thing that I want you to see here is this lead 3, and this is the Q wave. Okay, Q wave. I want you to remember that there is a Q wave which is peaked here. Okay, we will talk about this in later in this video, and this Q wave concept is very important for the myocardial infarction. Okay, so just wait till we reach there. Okay, before that let's discuss about the left ventricular hypertrophy. So normal this is the normal vector V6. Okay, and this was the vector because of the left ventricle, this was the vector because of the right ventricle. Okay, now there is a hypertrophy of the left ventricle, so let's denote the normal values. That was 100 minus 30. Okay, these are the hypothetical values, they are having no significance, but we are applying some magnitude to these vectors so that we can easily check the direction of the resultant vector. Okay, I hope you are getting my point. And now there is hypertrophy of the left ventricle, so now the resultant vector will be having more. So now the magnitude of this left ventricular vector is suppose 150. Okay, and the resultant vector was 70. Now the right ventricle is having the same minus 30 as the magnitude. Now the resultant vector will be more towards the left ventricle, and the magnitude will be 120. So this will cause more more of the left axis deviation. Okay, so the resultant vector go more towards the left side. Okay, and this is a very simple concept, guys. And if we look towards the normal ECG of these persons, so we will first check in the V1 lead and then V6 lead. So normal ECG in V1 will look like this. Okay, R wave because of the septal depolarization, S wave because of the ventricular depolarization. Now the septal depolarization will remain the same, but in the ventricular depolarization there will be more negative S wave. Why? Because now the vector is going more towards the left side of the heart. Okay, so and now in the V6 we were having a Q wave. Q wave was because of the septal depolarization, then R wave because of the left ventricular depolarization, and the normal baseline. Now abnormally, after the left ventricular hypertrophy, there will be a Q wave and a peaked R wave can be seen. Okay, peaked R wave can be seen. So now let's discuss this ECG, which is obtained from a person having left ventricular hypertrophy, and as you can see, there is a long S wave, negative S wave in V1 lead. Okay, this is S wave, and also a long R wave in the V6 lead. Okay, V6 lead R wave. So this is the most important finding in the left ventricular hypertrophy, that you will see a negative V wave, negative S wave in lead V1, and more positive R wave in the lead V6. Okay, so there is nothing to remember in this ECG. This is all about the concept of the ECG. Okay, also this left ventricular hypertrophy can also elicit and the inverted T wave. Okay, so see here, V5 and V6 will be having inverted T wave if there is left ventricular hypertrophy. So V1, 2, 3, 4 leads will show inverted T wave in right ventricular hypertrophy, and V5 and V6 will show inverted T wave in left ventricular hypertrophy. Okay friends, now the very important part of this video is the Q wave, and how this Q wave have significance in myocardial infarction. So friends, normally why we get Q wave? This is V6 lead. Okay, normally what happens, that this is the normal ECG of the lead, normal ECG obtained from the lead V6. Now this Q wave is because of this septal depolarization. Okay, if I draw a diagram of the heart here, okay, and here is the septum, here is the septal part. Okay, and the depolarization wave in this septum is going from left to right side. Okay, and that is giving us a Q wave in lead V6 normally. Okay, but please try to learn this concept, because it is very important. Okay, so this was the normal physiology why we get Q wave in V6. Okay, there is a depolarization. Now why we get this R wave? Because there was a depolarization in the ventricle. Okay, now friends, what happens in the myocardial infarction? There is death of the ventricular muscle. Okay, now this muscle is now dead here. Okay, because it is dead, if it is completely dead, suppose it is completely dead, and because of this there is no conduction in this part of the heart. Okay, there is no conduction in this part of the heart. Now our lead is looking towards this side of the heart. Okay, now guys, this will create a electrically neutral window here. Why? If I put my camera here, okay, we are looking from this side of the heart. Okay, so what I will be seeing is, this is the wall of the heart. Okay, we are looking after sitting here. Okay, we are sitting here and we are looking in this direction. So this is the wall of the heart. Okay, this is the wall of the heart. Okay, left ventricle, and this is the window. Okay, by this window I am saying that there is septum and this septum is getting depolarized from left to right. Okay, so the vector of this depolarization is going away from me. Okay, it is going away from me. Okay, I am sitting here, I am seeing from this side, and I can see that there is a vector going away from me. Okay, I am lead v6. Now because of this, earlier when there was no infarction and no damage to the muscle of this heart, of this side, there was no window. Okay, because of that, the depolarization wave in the ventricle was masking the depolarization wave of the septum. Okay, after a particular time. Okay, so let's discuss it again. Okay, it is very important. So the QRS complex. Okay, now Q wave is because of the septal depolarization. Now depolarization in the septum is continuing while we depolarize the ventricle. Okay, because of the depolarization of the ventricle, the resultant vector is going towards the V6 lead. Okay, and because of the resultant vector going towards the V6 lead, there will be a R wave. Okay, and this Q wave has a certain height. Okay, and it is very short normally, but because there is a death of this tissue here, we can directly see the septum from this electrically neutral window. Okay, there is no hole in the heart. Okay, I am not talking about the hole, but there is some electrically neutral tissue there which is having no depolarization wave. And what we are catching, what we are seeing, we are only seeing the depolarization waves. We can only check the vector. Okay, so because of this neutral window, we can see the septal depolarization. Okay, now because of this, there will be a increased in the depth of the Q wave. Okay, there will be a increase in the width of the Q wave. This is the pathological finding of the myocardial infarction. Okay, so this was very important. I hope you got my point. If you have not got this point, please ask in comment or ask in DM. I will describe it again. Okay, so this was the basic behind the abnormal Q wave. Okay, so the ventricles are depolarized from now. This was the concept, and one thing you always remember, that the ventricle get depolarized from inside to outside. Okay, now with this, let me discuss one more important concept, that is about ST segment. So about ST segment, and you have heard the term STEMI. Okay, STEMI is ST segment elevation myocardial infarction. Okay, ST segment elevated myocardial infarction. So a myocardial infarction which shows ST segment elevation is called STEMI. Now why there is ST segment elevation? There are a lot of theories on this, but the most accepted theory is that there is no ST segment elevation. Okay, so what does that mean? Let me discuss it here. So suppose guys, here is one line. Okay, and here is the another line. You can say that these both lines are in a in one line. Okay, these both lines are in a plane. Okay, in a 2D plane. Now suppose I want this second line to get elevated. I want this second line to be superior than the first line. There are two methods by which I can do this. The first one is I remove this second line and draw it above the first line. Okay, now the second thing what I can do is I can remove this first line and draw it below the second line. Okay, that is the thing which is happening here. ST segment is not elevated, but the proximal part of the ECG, which is you can say PR interval. This PR interval is below the normal line. Okay, and that is giving us the effect that there is a ST segment elevation. Now, what is the concept behind this? Why this is happening? Why there is lowering of this PR interval? Why it is happening? So guys, the basic concept is the first part in this PR interval, the baseline is showing us the repolarized state of the ventricles. Okay, are you getting my point? So this repolarized state of the ventricle. Now suppose normally what happens, because of the repolarized state of the ventricle, this baseline, okay, let's discuss it. So okay, so this baseline is at 0 millivolt. Okay, no problem. Now the problem starts when there is infarction, and there is a problem, there is death of the tissue. Because of the death of the tissue, first it is creating a window which is giving us the Q wave. The second thing what it is doing is this dead tissue also originate a depolarization wave. Okay friends, are you getting my point? This is very important part. This dead tissue also originate the depolarization wave, which is going away from the lead V6. So this depolarization wave from this dead tissue is going in the opposite direction of the normal ventricular depolarization vector. So this tissue which is good, okay, this tissue which is healthy, also this tissue which is healthy, these are having depolarization vector in this direction, okay, in this direction. But this dead tissue is having depolarization vector opposite to normal direction. Okay, now in the repolarized state, when there is no depolarization, there is no wave from this normal tissue. Okay, no depolarization wave from this normal tissue, but this abnormal tissue is still depolarizing in the wrong direction, okay, in the opposite direction. That does mean that this baseline will not be at the 0 millivolt. This will be lower than that. Okay, you got my point? This was the very basic concept behind the ST segment. Okay, and the same concept applies for the Q wave. So I am connecting this both. Okay, so we talked about the Q wave. Now we talked about that there is no ST segment elevation. The segment which is the PR interval is decreased. Okay, the PR interval is below the normal. Okay, that is normal repolarized state. Now what will happen then when there is a QRS complex? Okay, so this Q wave will be more. Now can you relate this negative depolarization wave, which is going in the opposite direction with this Q wave? Can you relate it? Yes, because of this negative depolarization wave. Okay, because of this negative depolarization wave, we will be having a peaked Q wave. So there are two factors helping in a peaked Q wave. The first one is this window. The creation of this window will give us more peaked Q wave in the negative direction, because we will be catching the vector from the septal depolarization, and also this depolarization vector which is originating from the dead tissue, which is opposite the direction of a normal, that will also give us the more negative and peaked Q wave. Okay, so I tried to make it more simpler for you guys. Even if you can't understand it now, please ask in comment box or DM me. Okay, DM us. Now picked Q wave. Okay, then there will be R wave. Okay, now this R wave, now because of this R wave there is depolarization. Okay, now more of the depolarization, more will be the R wave. Okay, now this line will approach the baseline, which is 0 millivolt. After that there will be repolarization in the form of T wave. Okay, and after this T wave depolarization, there will be repolarization in a form of T wave. Okay, now after this repolarization, the same thing will happen again. What will happen? This baseline will again be in the negative direction, in the lower side. Okay, and why? Because the dead tissue is still sending the depolarization vector in opposite direction. That was the very basic about the myocardial infarction, STEMI and the Q wave. Now one fact is that you might have heard about the NSTEMI or non-ST segment elevated myocardial infarction. So this non-ST segment elevated myocardial infarction was previously called as non-Q wave infarction. Okay, but then the name was changed and now it is NSTEMI, non-ST segment elevated myocardial infarction. Now what happens in this? It is the concept behind it is same as the STEMI, but the thing is the muscles are not completely damaged here. Okay, so there is no window, as there is some muscle mass remaining which is not degenerated till now, which is not dead till now. Okay, so there is some muscle mass here. Because of this there is no window, and again because of this the dead tissue, the vector because of the dead tissue and the vector because of the normal tissue will cancel each other. Okay, so because of this there will be no ST segment elevation that can be seen here. So guys, that was the basic concept and the purpose of this video. It was very important for you. Okay, now see this photo which illustrates the same thing that I was telling you, that we are sitting here. Okay, and we are looking in this direction. So what we can see is the septal depolarization. Okay, and that is giving us the more Q wave. Also the negative, also this, see this, the depolarization vector because of the normal tissue is away from the heart, but the depolarization vector because of the dead tissue will be toward inside the heart. Okay, so that will also give us the peaked Q wave in lead V6. Okay guys, so now let's check this ECG. Yeah, one important thing is that by the location of the ECG, by the location of the lead in which we are finding the abnormality, we can say what is the direction of the, what is the location of the infarct. Okay, so that is how the ECG helps us to remember and to diagnose the condition in myocardial infarction, because it can also give us the information about where the infarct is located. Okay, so now if the infarction involves both anterior and lateral surfaces, suppose infarction is involves both anterior and lateral surfaces, so the leads which are looking towards the anterior and lateral surfaces will show the abnormal Q wave. Okay, so the Q wave will be present in the lead V3 and V4, and also lead that look towards the lateral surface. So what are the leads that are looking towards the lateral surface? That is lead 1, that lead VL, and also lead V5 and V6. Okay, so if there is infarction which is present in the anterior and lateral surface of the heart, the Q wave can be seen in lead V3, V4, V5, V6, lead 1 and lead VL. Okay, now suppose infarction of the anterior wall, there is infarction in the anterior wall of the left ventricle. Okay, so what are the leads that are looking towards the anterior wall of the left ventricle? Okay, leads that are looking at this side, at the heart, from this front will be V2, V3, V4 and V5 lead. Okay, so let me make a diagram to make it more clear and easy. Okay, now if I draw the leads, although I cannot precisely locate the lead and the heart because there is some physiological deviation, but this is 1. Okay, lead V1, V2, V3, V4, okay, and V5 and V6. okay, so look in the three-dimensional way. Okay, V5, this is V5 and V6. okay, so if there is something there is any problem in the anterior side of the left ventricle, this is left, this is right, anterior side of the left ventricle, the deflection and the Q wave can be seen V3, V4 and V5. okay, V2 can also be involved in this. okay, V2, V3, V4 and V5 we will be seeing the abnormal Q wave. okay, we have already talked about the anterior and lateral surfaces. So anterior and lateral surfaces will include V3, V4, V5, V6 and lead 1 and VL. okay, lead 1 and VL are the leads that are looking three-dimensionally towards the heart. okay, also if there is infarction in the inferior surface of the heart, okay, inferior surface of the heart, so the lead that is looking from the inferior surface of the heart will have the abnormal Q wave. So there are two main leads that are looking from the inferior surface of the heart, that is with the lead 3 and lead VF. okay, lead 3 and lead VF are looking towards the heart from the inferior side. So if there is any infarction which is from below, then the lead 3 and VF will show as a abnormal Q wave. If there is a infarction, now this is important guys, if there is an infarction in the posterior wall of the left ventricle, so we does not have any lead which is looking from the, at the posterior wall of the left ventricle. So okay, so here is the important part. As the right ventricle having more anteriorly and left ventricle is more posteriorly. Now what happens, let's talk about the lead V1. okay, so the normal finding in the lead V1 was like this. okay, the R wave because of the septal depolarization, S wave because of the ventricular depolarization. Now this S wave was influenced more because of the left ventricle, as we have talked about multiple times that the left ventricle is having more muscle mass. okay, now because of the infarction there will be less influence of the left ventricle on the ECG. So you can see there will be this peak of the S wave will be less. okay, peak of the S wave will be less in this lead V1. okay, that is a finding that can be seen if there is a infarction in the posterior wall of the left ventricle. okay, and also if there is less S wave, okay, less S wave, so there will be more of the R wave. Why more of the R wave will be there? Because the depolarization vector is now more towards the right side. okay, so this R wave will be peaked. Now guys, there is a contradiction here. We talked about the same thing in our right ventricular hypertrophy. okay, in the right ventricular hypertrophy same thing was happening. Because the vector was going more towards the right side, there was peaked R wave and the S wave was less prominent, less peaked. okay, and the same finding we can see here in the lead V1 because of the infarction of the posterior wall of the left ventricle. Then what will be the finding? What will be the change? That we we should see to differentiate between right ventricular hypertrophy and this. So the change is the T segment, T wave inversion. In the right ventricular hypertrophy, you can see the T wave inversion in which lead? V1, 2, 3, 4. Okay, V1, 2, V1, V2, V3, and V4. But in this, the infarction, because of the infarction, there is no hypertrophy. Okay, so you will not see the T wave inversion here. So that was a characteristic finding. How can you differentiate between right ventricular hypertrophy and the posterior wall infarction? Okay, now the age of the infarction cannot be determined by the Q wave, and also the Q wave, if it develops, it is permanent, usually permanent. Okay, if once the peaked Q wave is there, it will be always be permanent. Okay, now let's talk about the different ECGs and that is showing us the myocardial infarction, and try to locate their position via this ECG. Okay, now let's see this ECG, and let's try to find out the important findings in this ECG. Okay, so the first one is, let's first discuss about the inferior infarction. So if there is inferior infarction, what will be the findings that you can see in the ECG? We will be seeing in the lead 3 and lead VF. Okay, we just talked about that if there is any infarction located in the inferior wall, there will be changes in the lead 3 and VF. So see this, in the lead VF you can appreciate the peaked Q wave. Okay, also in the lead 3 you can appreciate the peaked Q wave. Also in the lead 2 you will be appreciating the peaked Q wave. Okay, and can you see any T wave here? Any T wave? Okay, here is a T wave which is inverted, and also here is a T wave which is inverted. Okay, so these are the signs of the T waves that indicates the old infarction, old inferior wall infarction. Okay, so guys, it is very important to locate the Q wave. Okay, peaked Q wave is very important in the myocardial infarction, more than the ST segment elevation. Now let's talk about the infarction which is associated with the acute anterior. Okay, the findings which is associated with the acute anterior infarction. So for the acute anterior infarction, what will be the leads that we will be seeing? Which are the leads? That will be V2, V3, V4. Okay, so see here, Q wave, Q wave, Q wave. Okay, it is even in the V2 lead there will be peaked Q wave. Okay, V4 is also showing a peaked Q wave, although not that much, but it is showing. Okay, now see here, this, can you appreciate this? These are the finding. This is the ST segment elevation. Okay, so this is the ST segment elevation. Now guys, I want you to look here. So the baseline of this ECG was this. Okay, let me not cheat and let me try to make it more straight. This was the baseline. Okay, a small inferior. Okay, now you can appreciate that this if I draw it more, every time the ST segment lies on the baseline, almost every time. Okay, although there is some elevation in the lead V4, but can you appreciate the decreased baseline in the previous part of the QRS complex? Okay, previous part in the PR interval. Okay, that's what I was talking about. Okay, that's the point of the basic concept that we talked about, that there is a relativity behind this. ST segment elevation and the PR interval depression. Okay, and that is very important. Okay, so let's again come to the main point. So the anterior infarction can be located in the lead V3 and V4. Okay, now let's talk about the next ECG, which is showing us the we know that this ECG is of a myocardial infarction patient, but we don't know the location of the infarction. Okay, so what we will be looking towards, we will find the Q wave first. Okay, so in which lead you can see the Q wave most prominently? Can you appreciate anywhere it is located, if you can find it anywhere? Okay, so the most important okay, let's start with the first. Can you appreciate here? No. Okay, V2, can you appreciate? No. V3, can you appreciate any Q wave? I don't think so. Okay, it is, although it is prominent, but it is not that much significant. Check in the R wave. Can you appreciate? No. Okay, see, VR wave can normally show inverted T wave. Okay, so normally it can be present there. Now see, in this lead VL there is a significant Q wave that can be seen. So there is the VL lead is showing us the Q wave. So what can be the location of the infarct? Come on, it can be of lateral side. Okay, now to confirm if it is only lateral side or it is anterior lateral side, we will be checking lead V2 and V3. Now when I go to lead V2 and V3, there is a messed up ECG that you can find here. In this ECG you can see a peaked Q wave, ST segment elevated, and T wave and inverted T wave. Everything is messed up. Okay, and that is so that is present here, and that is showing us the anterior lateral infarction is there. Okay, so anterior lateral infarction is present there. After this, let's talk about the next ECG. Okay, this ECG. Now in this ECG we will be talking about the we will be checking the position of the infarction. Okay, so here I can locate it here, the Q wave. Okay, significant Q wave is here. Okay, also let's if there is Q wave, significant Q wave can be found in the lead 3, that means there is an infarction in the inferior side. Now to confirm my diagnosis, I will be checking the lead VF. There is a Q wave. Okay, although it is not that significant, but because there is Q wave inside in the third lead, then I can make the diagnosis by the even in this a small Q wave that it is infarction in the inferior side of the heart. Okay, and also check the lead VL, and in this lead VL you can see the abnormal T wave inversion. Okay, so abnormal T wave inversion can be seen in the lead VL, although the most significant part of this ECG was the Q wave that can be seen in the lead 3 and also lead VF. With this, can you appreciate the elevation of the ST segment? Okay, so that is also important, ST segment elevation. Okay, so that confirms our diagnosis of this ECG having the infarction. Okay, now let me again draw the baseline to confirm the theory of the relativity of the the theory of the relative elevation of the ST segment. So if I draw a clear, which is already drawn, okay, one line is already drawn in the ECG. See, the baseline was below. Okay, baseline was not on the base where it started. Okay, so there is a relative elevation of the ST segment. Okay, and rest ST segment can be seen in the third lead, also in the also in the VF lead. Okay, now the next ECG, which is this ECG is very important. Why? Because it is showing us the check this. Can you see there is a increased height of the R wave and the decreased height of the S wave? That does mean there can be two things possible. One is right ventricular hypertrophy, the second one is posterior wall infarction. Now to confirm my diagnosis, I will be checking if there is any inversion of the T wave. Can you see any inversion in the T wave? There is not no significant inversion of the T wave. Okay, also in lead 1 there is a flattened T wave, and lead VL we are also having a flattened T wave. Okay, so but there is no inversion of the T wave. That does mean there is no inversion, no inversion, no inversion, no inversion, no inversion. Okay, that does mean that it is showing us there is an infarction in the posterior wall of the heart. Okay, posterior wall of the left ventricle. So guys, this was the very basic concept behind the myocardial infarction, and I hope I cleared your doubt and cleared your concept about the infarction. If I was unable to clarify the doubt, please ask in comment box or DM me your doubt. Okay, now this is a normal photo that is showing the elevation of the ST segment. There can be a depression of the ST segment. This depression of the ST segment can be mostly because of two reasons. The first one is exercise and the second one is digoxin. Okay, so digoxin we will be talking about the in the end of this video. So ST segment elevation, we have already talked about this, why it is happening, why and how it shows that there is myocardial infarction. We have already talked about this. Okay, with the Q wave. Okay, now suppose I take a ECG from a person. I take first see this ECG, guys. This is showing the depression of the ST segment while the person exercises. So this can be present, and this can be normal. Okay, now see this, guys. These are the changes from the point the pain started to the patient. Okay, so we have taken ECG of 24 hours of the patient who is having pain. Okay, so the first hour after the onset of the pain, what we can see in the ECG? What we can see in the ECG is the C. Is there anything that can be wrong, that you can see is wrong here? Tell me. Okay, this is normal, guys. The first ECG here is normal. Okay, after 6 hours you can easily appreciate two things here: Q wave and ST segment elevation. Q wave, ST segment elevation. Okay, although the lead V1 the lead 1 is not showing the much of the Q wave. Okay, significant Q wave cannot be seen in the lead V1, lead 1. Okay, now see this, there is a Q wave in lead VF. Okay, now can we signify the position of the infarction by just looking at this ECG? Okay, can you tell me the position of the ECG? It is located in the inferior side of the heart. Why? Because there is Q wave present in the lead 3 and VF. Okay, although we are going we will be going for the further diagnosis of this, but the expected site of this infarction is the inferior side. Okay, now also the ST segment is depressed in lead VR, VL and lead 1. Okay, ST segment is depressed here, and now the ECG which is obtained from the after the 24 hours of the onset of the pain. So after the onset of the 24 hours, I told you about that the Q wave is becomes the permanent. Okay, So Q wave is permanent. You can see permanent Q wave here, and ST segment has come again to the baseline of the heart, and now see the lead 3 and lead VF. Can you appreciate the inverted T wave here? This inverted T wave, this Q wave, peaked Q wave, and in the lead 3 and VF. So here is one ECG which is of a person who is having no non-ST and STEMI, non-ST elevation MI, myocardial infarction, and there are 4 findings that we will be seeing here, and that is most characteristic finding. And the first one, which is this biphasic T wave. Okay, biphasic T wave in the lead V2, inverted T wave in lead V3, inverted T wave in lead V4, and also biphasic T wave in lead V5. So that is very important findings. That is very important 4 findings that can be seen in this ECG of a person of NSTEMI. Okay, suffering from NSTEMI. Now guys, what are the reason behind this? What is the concept behind this? Why it is happening here? And please try to figure it out by yourself. Okay, you know each and everything about the concept of the ECG, and I believe in you that you can easily find out what is the concept behind this. If you cannot, then just comment in the comment section, or you can DM me, and then we will discuss this thing, why it is happening here. Okay, so some other important things that can hamper this ST segment and T wave, that is the abnormal levels of the electrolytes. Okay, so the electrolyte balance. Now suppose the potassium level is low in your body, so I have talked about the U wave. Okay, so U wave will be elevated in this ECG. So if there is low potassium level, the T wave, which is showing the repolarization wave, repolarization of the ventricles, will now get more flattened. Okay, and the U wave will be more prominent. Now the if there is more of the potassium, and there will be more of the repolarization, the T wave will be of more peak. Okay, now this T wave will get this peak from the ST segment. So ST segment, the length of the ST segment will decrease. Okay, and also low plasma calcium level can also cause prolongation of the QT interval. Okay, and a high plasma calcium level shorten it. So that is also a finding that you can get via this. And the levels of the effect of the abnormal magnesium level are same as for the potassium. Okay, so that was all about this part of the ECG, guys. And by this video we are finishing with the first part of the ECG series, which was the basics and some very important clinical scenarios. Okay, and from the next video we will be starting a different part of the ECG, a different side of the ECG, in which we will be discussing about the individual ECG and some important aspects, and we'll go more deeper into the concepts. If you are liking the this ECG series, please hit like button, and also if you have any doubt, please ask in comment box, or you can DM us your doubt. Thank you guys.